I am Rachel Hogg Graham, and I'm an associate professor in the Department of Health Management and Policy in the College of Public Health at UK. Today, I'm going to give you a really high level overview of social determinant of health screening and intervention. Why screen on social needs? So, increasingly, we are understanding that health has very little to do with the clinical care that happens often in the four walls of hospitals, physicians' practices, and other clinically oriented organizations. We know that often it's the socioeconomic factors, the physical environment, and the health behaviors that are often influenced by those factors that determine what really goes into an individual's health. So, what do we mean by socioeconomic factors? These are things like education access and quality, healthcare access and quality, economic stability, social and community context, and the neighborhood and built environment. So, in the last probably 10 years, there's been a real surge and push to have clinical organizations think about social needs screening as part of their workflow. So there have been a number of policies and programs that really incentivize social determinant of health strategies. Just a few of those include some of the CMS screening requirements, like those that are going to go live for hospitals in January 2024. Accreditation, both local public health and hospital accreditation, are now wrapping social determinant of health screening into their equity strategies. Public Health 3.0, which really thinks about multi-sector systems and how clinical and community partners can work together to think about community context and addressing needs, and value-based programs that incentivize lower spending, really have folks thinking about how you cut that cost curve and think about some of those other factors outside of clinical care that might influence things like readmissions and other types of hospitalizations. So to effectively address social needs requires this multi-sector approach to care. So this is really that intervention piece. If you're going to be a hospital or a physician practice clinic that's screening, you've got to be able to send the person somewhere. You shouldn't have to provide the food security services, the legal services, the housing services, but you should know where in the system the individual could go to get those. So that might be your local community-based organizations and nonprofits, be your local health departments, could be something related to schools, law enforcement, local government, social services, a number of different types of community organizations that really provide those social needs services that can help patients address what they've identified in the clinic. So what does that system look like? Often we think it's very linear, that an individual might enter into the hospital, be screened on their unmet social needs, then referred out directly to the community organization that can meet those needs. Really fancy graphic here, but this is what that system actually looks like. It's complex, it's fragmented. There are lots of barriers. We know that often patients come in and get screened, try to get to a service, find that maybe they don't have the right paperwork, that they've already taken a day off for work, can't come back. They move to one organization and get there and need to go to another organization, or they end up needing to come back to the hospital, are brought in for a readmission or an ED visit before they actually get to those social services. And then we also know there's a lot of patients that never enter into these systems. They don't get the clinical care where they're screened. They're not entering into the social services either. These are really, really complex things for researchers like us to understand and navigate. So we know that for patients and individuals living in the community, they're also very complex and hard to navigate. So what are some of the common challenges in the social needs screening and intervention space? One absolutely is financing. So if you are a hospital or clinic setting up a social needs screening workflow, how are you going to finance that? Who's going to work that? What is that going to look like? Do you need additional tech, electronic health record services? Where is that money going to come from, especially in a place where you might be asked to remain budget neutral? The second piece, which really ties to financing, is capacity to screen and manage referrals. So we know that you're going to need to have folks that help watch that screening process, even if you are doing it electronically in a MyChart or something like that, and then manage that referral. So when somebody is flagged with an unmet social need, how are you going to ensure that they're triaged? What's that going to look like? And then connect them with those community resources. Third, the who, what, where with community resources. So it can be incredibly challenging to identify the community partners in different spaces. Who are they? What kind of services do they provide? Who's the contact there? We know that these lists are often very fluid, that people move in and out of jobs, organizations can close. There are expensive services that create community repositories, but what we have found in some of our research is even those community repositories aren't always accurate or up to date, that they are often just scrubbing the internet. So how are you going to keep that community resources list in place? Fourth, closing the referral loop. So this is one of the really challenging pieces in this space, that we know when you set up a internal screening and referral piece, that often it's that community connection where individuals fall off this cliff. We don't know where they go. Did they receive the services? What did that look like? So closing that loop with your community partners who often don't have sophisticated tech capacity to understand and make sure your patients are getting the community services that they need and having those unmet social needs met. Patient interactions and refusal of services. So we know that screening on unmet social needs is very different than screening on clinical needs. Being able to tell someone that you're housing insecure or having other challenges is really different than finding out that you have high blood pressure or something like that. So really thinking about dignity in those patient interactions and understanding that patients often refuse services. There's a long history with many of our marginalized communities and subgroup populations in care. It might be harder for them to accept services and be trusting of some of these mechanisms being put in place. Last, partnerships and relationship building. So it really goes back to that community piece. We know that community organizations are critical in this work, that they are the ones that can address the unmet social needs. So really thinking through building strong relationships, sustainability, trust. We know that partners often feel like they're brought in on the back end of social needs screening and referral efforts, that it makes a lot more sense to have them on the front end, have them providing their input, building those relationships. That way, going back to the who, what, where, you know who the who is, you know who the person is there, you connect with them, you can think about closing that referral loop and really think about sustainability in that partnership and how you keep that going in the long term. Most folks want to put together these social needs screening and intervention strategies for many years, not just kind of a quick testing out. So thinking about those relationships and what they're going to look like. And that might be particularly challenged at a place where you serve people across many different geographic regions. So what will be your potential strategy for that? So just a few key considerations when moving forward with a social needs strategy. And a lot of these will tie back into some of those common challenges. So a clear internal workflow. What is that internal screening and referral management process going to look like? Are you going to do it in the EHR? Are you going to use one of the CAN surveys? What's your survey going to look like? Are you potentially going to use MyChart? What happens when somebody needs to have help with the survey? Are you going to have a point person in the room to do that? Is that going to be part of the nursing staff? Lots of different options in this space, and happy to talk more through some of those strategies, thinking about what works best for your organization. But what is that workflow going to be? Make it very clear. That way you can kind of troubleshoot some of the different pieces and really make sure that the screening happens effectively so that you can then push them out, manage that referral. What's that piece going to look like? Are you going to triage based on the number of needs identified and some of those pieces, and then refer them out to the community resources? How you screen and patient interaction. So like I mentioned, what kind of screening are you going to use? What questions are you going to ask on? Are you going to make sure that you have it in multiple languages, and making sure you train your staff on how to interact with those patients? Really thinking about asking very personal questions here, making sure that you can help them maintain dignity, ask them in a sensitive nature, and really build trust between that social needs screening referral team, management team, and the patients in your setting. Connection to community resources. So what is that referral process going to look like? How are you going to make sure that patients exit the four walls of the clinic or the hospital and then get out to those community resources? Are you going to potentially have a port person separate than your internal workflow to manage that, and thinking through those connections? Who are the right people? What services are available, and what does that look like? That ties directly to the building strong relationships with community partners. We always say earlier, better. So making sure as you're developing these social needs screening strategies, you're bringing your community partners in and having conversations with them right off the bat. So that might be nonprofit community-based organizations, it could be your local health departments, it could be local government services, but really trying to let them know what's happening. We find that often they don't realize that a major social needs screening strategy is being put together at a hospital or a clinic that could and potentially influence their capacity to meet the needs of the clients in their community. Building out those relationships, letting them know, building trust, breaking down barriers because they are your critical partners in that intervention piece. And sustainability goes back to financing, relationships, that internal workflow, all of these pieces. Really think through your strategy as you set it up. Is it something that's going to be sustainable? What would financing look like? How do you help build capacity in the community? Just some key considerations there. And then document and evaluate. We know that this can be your biggest tool, especially thinking about effectiveness and sustainability and advocacy to some of these national organizations pushing these requirements. What works for who, where, what does that look like? Where can you evaluate and lay some quality improvement on the process? Think about places where things might go wrong as you're setting it up. Perhaps something was wrong in the electronic health record, or you're having challenges with that community resource connection. That way you can go in and tweak it and make this work much more effective and beneficial for everyone. So absolutely a very high level overview. I think we could talk for hours about each one of those challenges and key considerations. I hope this information has been helpful as you start to think about your social needs screening and intervention strategies. As I said, absolutely, please feel free to reach out with questions. Our team is heavily embedded in this type of work, especially thinking about the community capacity and resources pieces. Happy to talk with folks and troubleshoot. Thank you so much for your time and have a great day.